Thank you, sir. Good morning, everyone, and thank you, chairpersons. I hope I'm audible and my screen is being shared.
Yes, sir.
Yeah. I think that we do not have Dr. Niti and Dr. Ninad is not there, so the rest will be there. And welcome panelists, Dr. Alurkar from Gujarat and Dr. Rakesh from Guwahati, Dr. Babita again from Gujarat. We have Dr. Devendra from Mumbai and Dr. Ravindra from radiation oncologist from Jaipur. So that's it, and we go down, and it will be a 20 minutes panel. So I don't think we will be going into details, and I would request my panelists to be to have very short answer, crisp answer. 20 minutes. I don't want to long go on to beyond 10-20. So this was for the surgeon because it was a panel for 20 minutes. I didn't think I could have more questions, and I can just probably ask my chairperson to just take this before you go ahead, sir. Would the nodal clearance be for you today for stomach cancer be a D1, D2, or you just do without a nodal clearance and think that chemoradiotherapy will be good enough? Dr. Sanjeev. Okay. So, Dr. Arulka, Dr. Sanjeev, sir, can you take this before we go to?
Yeah, sure.
Yeah.
I think
That's
when we're
quick
talking
answer. Yeah.
stomach and surgery, a D2 clearance is something which I would say. Simply removing the primary and not addressing the nodes would be incomplete. I would not go for that.
So a D2 is something which you want to achieve for. You might
Yes,
miss
but
in some one, but at least a D1,
something
but
of a
definitely D2.
D1/D2. That's what D1 and a half.
Okay, but D2 is what you will
Yes,
always
yes,
want to achieve.
yes.
Okay, so that's a point very, very important for all of us looking at medical oncologists. We should look at the clearance, and if it is a D2, that's what the optimum surgery for an operable cancer stomach would be. There was even a Dutch trial which showed that even a D1 needed a good adjuvant therapy, and D2 actually the adjuvant therapy did not help much when you went ahead, and radiotherapy did not add on to that. So, Dr. Arulkar, neoadjuvant versus adjuvant, what is your take on the stomach cancer? Quick one-liner, and what is the appropriate regimen?
If you're talking of GE junction, I would go for the FLOT
only
regimen.
gastric. Let's restrict only gastric. It's a gastric cancer.
Okay. So gastric cancer basically taxane based, mainly docetaxel or cisplat-5. You would be the best.
So you would
regimen.
go like a FLOT-like regimen.
Something like a FLOT, yes.
Okay. So Dr. Devin, FLOT-like or ECF is still good enough? Dr. Devin, you're there? Dr. Rakesh Mishra?
Sir, I'll go with the FLOT-based regimen. I prefer FLOT better than the ECF.
Okay, so there are two things. What is really happening that there is a trial comparing ECF and FLOT was superior, but it is a thing that needs the toxicities were much more in FLOT. You could also go with the FOLFOX-like regimen in a stomach cancer and take out the taxanes. That's also all are appropriate options, but ECF is getting out. It is no more a standard of care as of now. Very few of us use ECF. So, Dr. Babita, in your center, does all stomach cancer are referred for chemotherapy, or a surgeon operates and directly wants to go ahead and operate everything? Dr. Babita, you are there?
Dr. Babita, you are muted, please. Unmute yourself.
Request the panelist, because it's a very short panel, very short time. We want to make out only the important points.
So if I may add, Dr. Sahoo.
Please.
Actually, if I may take that question, there are a lot of, I think the surgeons are good enough to realize that those who have a little bit of a locally advanced or a bulky tumor, they are referred for neoadjuvant chemotherapy. And of course, if there are N1 nodes are seen, they are referred for neoadjuvant, and they don't go for surgery right away.
Okay.
And obviously, again, what I would also suggest was FLOT would be more useful in people who are medically fit.
Yeah, agree.
For patients.
So for that point, all of us agree that neoadjuvant chemotherapy, FLOT is acceptable regimen. FOLFOX is one of them. You can also go for ECF, but it is shown to be inferior to FLOT. But toxicities wise, that's the point we discussed. Dr. Alurkar, all or someone are referred and which beyond which should receive neoadjuvant? Quick one, 10 seconds.
Sorry, repeat the question.
Which patient should receive a neoadjuvant? Dr. Babita felt node positive. Would someone who would be going for a neoadjuvant chemotherapy?
I think based on the evidence, practically all patients are now the candidates for neoadjuvant therapy.
Anything beyond stage 1B, ideally now should go for a neoadjuvant chemotherapy. That's what the practice is, and I think we have to change, as in change esophagus. Stomach also operable upfront only for a obstructive, probably bleeding lesion. Otherwise, most of the patients would go for a neoadjuvant. Okay. So now I go to my radiation oncologist, Dr. Ravindra. Can you unmute yourself? Do you feel in this world, when you have done a D2 resection, is there any role of now radiotherapy in stomach cancer? Do you have it? Okay. So I'll move on because there's less time. The only point what comes through to the critics thing is, if you have optimally debulked and optimally operated, the option of there was a trial which post neoadjuvant surgery went ahead and compared chemoradiotherapy versus chemotherapy adjuvant, and they did not find any advantage of a chemoradiotherapy versus adjuvant chemotherapy. So with that starters, we now go to the setting of metastasis for the next 15 minutes. It's a 57 years old man diagnosed as stomach cancer, had no bleed or obstruction, had 3 liver deposits, ascitic fluid was positive, histopathology adenocarcinoma grade 2. So what next? This is what I'm giving you, Dr. Alurkar, HER2 3+ on IHC. Dr. Devendra, are you there? Dr. Devendra Pal from Mumbai?
No, sir. He hasn't joined yet.
That's okay. So we are 3 panelists. So it's also HER2 3 positive on IHC and PDL1 is 15%. What is your treatment of choice?
So now, if you talk only scientifically, then I'll use anti-HA.
Only scientific.
Okay, not the cost factor. Okay. And if it is scientific, then only anti-HER therapy with taxanes based on the TOGA trial.
So, now put the cost factor in today's world. When I'm getting a trastuzumab in 16,000 rupees, will cost me any more a factor? Because I know you charge 20,000 per cycle. So now tell me, Dr. Alurkar, what would be the choice now?
If a cost is a factor, you said?
Is not a factor. It should not be a factor.
It's not a factor. Then anti-HER therapy is along with.
Okay.
Based on the TOGA trial.
Okay. So this is one point of thought process which I was going through. I just looked at it. So if you look at it, even in 0 or 1 IHC, which is not recommended, you just take it as negative. If you do a FISH, there's amplification of HER2 in 7.85 to 8.5%. That's something which I thought, should we be doing a FISH for everyone, or should we be doing only for the 2+? So this is a passing thought, nothing to discuss about it, but to tell you across the trials, they found that IHC 0 and 1+, 7 to 8.9% patients do have amplification for HER2 by FISH. This
maybe
is what
only,
doctor. Yeah, please.
Maybe only in potentially affordable patient you can go for that.
That we can discuss someday. But only thing the recommendations are 3 is definitely, and as in stage 2, we need to do FISH. So for TOGA is what you spoke about, and the last speaker spoke about the other trials. It's a positive trial. That's what we do. There are other trials which were spoken about. Only to look at the lapatinib trial was not positive for survival. So now Dr. Rakesh, patient received trastuzumab, responded with a partial response with chemotherapy and trastu, and the progression of disease happened after 11 months. What next would be your standard of care if everything is there and you can take anything from anywhere in the world, or practically what do you do?
So in this case, sir, PDL1 expression was more than 15%.
It is 15%.
So we have the immunotherapy, pembrolizumab, as an option for the second line treatment in this patient.
Okay, so you would, which regimen would you want to use?
More than 10% pembrolizumab alone, I will go with in this patient.
Okay, you want to go for pembrolizumab alone. Dr. Babita, Dr. Rakesh wants to go in a good, fit, affordable patient to immunotherapy because of the high PDL1.
I would suggest in a medically fit patient, pembrolizumab with paclitaxel would be an option.
Any evidence to quote of why you thinking that
I don't remember the name of the trial, but it shows definitely shows overall response benefit.
Okay, we will come to that. There was a first line trial which looked at 062, and I'll come to that in a minute. That spoke little very differently from what you're speaking. Dr. Alurkar, Trastuzumab failed, chemotherapy, affordable patient. What would you do next?
Go for nivolumab based therapy.
Okay. So actually you have options, and there was a trial which was spoken about. If that is not available at this point, but at some point deruxtecan would be available. The destiny was there to show you that in HER2-neu failed cases, failing trastuzumab, this would be probably the drug of choice. You would go on hitting the target, and probably immunotherapy will come little later. But there's fair to be my panelist. There is data. And if you look at the attraction 4, this had patients who had failed HER2 targeted therapy. Even some of the Pembro trials did have, but most of them did show for attraction chemo plus nivo. But for Pembro, it is most of the time single agent which has shown the benefit. So now let's take a second case scenario. Upfront case, mind you, HER2 negative on ILC. The CPS or the PDL1 is high. What is now your treatment of choice? Dr. Rakesh, would you take this?
Here we have the option of immunotherapy as a front if the disease is not very symptomatic. If the disease
attacks,
immunotherapy plus chemo is what you would still stand by. That's fine. Let's see the evidence. And in one slide, I'll tell you the evidence. And Dr. Alurkar?
Yeah, I would go for the chemotherapy alone, reserve the immuno later on because there is more evidence for immuno working in second line and beyond.
Okay. So this is a scenario which is evolving. And Dr. Vineet Talwar is there. In the last comments, he can speak about that for some time. But most important is, do we have a single agent immunotherapy evidence? Do you have a chemo plus immunotherapy? And do chemotherapy is it option? Is it option? All the top 3 are options. And if it is chemotherapy, Dr. Rakesh, would you be single or dual or triplet?
If general condition young patient is there,
it's a fit patient. It's a fit patient, 57 years old.
57, I will go with the doublet, sir.
Okay. The standard of care usually is a doublet, irrespective of things. In a fit patient, you can go for a triplet, but there is actually not much of an advantage. So most of time it's a doublet. Now, this is what the NCCN tells you all about. That a 2 drug is the preferred because of toxicity, and there's no superiority of 3 drugs except for a very fit patient, but who can go on with the toxicities. This is what it was all about. The keynote 062 was looking at the gastric. I'm just looking at the gastric. The attraction 4 looked at the upfront, and it was chemo plus nivo. And if you look at this was Pembro versus Pembro plus chemo versus chemotherapy alone. And this is 062 unresected, previously untreated patient with the CPS more than 1. And this is what I meant, Dr. Babita. If you look at the chemotherapy and the Pembro arm, look at the top one, which is the chemotherapy versus the pembrolizumab arm, and look at the CPS more than 10. Actually, there is a benefit of survival is coming up. Look at the lower curves. It is chemo plus pertuzumab versus chemo, and it really does not score over. If you go back and look at this, the benefit of Pembro versus Pembro plus chemo, actually here, look at the CPS 10. Although statistically it was not analyzed, but numerically it is far, far inferior. It actually did as good as probably it did inferior to Pembro alone. But Nivo is a trial which really showed the chemo plus Nivo is actually superior to chemotherapy alone. So if you are doing Nivo, probably adding chemotherapy is an option. But if I'm doing Pembro, at this point upfront, it does not seems okay to me to add a chemotherapy. Dr. Babita, your thoughts now. Would you think that you stick to your guns and go for chemo plus Pembro, or you would go for a Nivo plus chemo if it is Pembro, it is single agent?
Well, I can't go against it.
It's okay. It's fair. No, the only thing I want.
The response rates are much better. Maybe the combination.
The response rate is actually also not better. That's the point I wanted to make also. So only thing is the checkmate 649, which Dr. Anand spoke to, and that also speaks about the same. That chemo plus Nivo also looked at, and it was found to be superior in terms of the primary endpoint of the PFS and the OS. So these are 2 options, but to tell you that none of them are approved till now, but these are options which will be getting approved in the next few months. So all of us as medical oncologists have to know these points. I think that is the point which I wanted to make, that chemo plus Nivo or Pembro are going to come in as an option for frontline, at least in a select group of patients.
What would you be offering?
I would be offering to my best patients. I have not offered immunotherapy last 1 year. So I look at the real lower straight of the people, Dr. Alurkar. So I for me it's chemotherapy, but I would love to do the immuno plus chemo. There's no doubt about it. If everything is feasible, I go for that. So patients progress on chemotherapy, choice of second line chemotherapy. So this patient was given only chemo, and then the patient progressed. So now would you give chemotherapy or would you give immunotherapy? Dr. Rakesh?
Here we have an option when we talk about we can go with the immunotherapy even without the PD-L1 testing. But I'll go with the chemotherapy.
You will also still now stick to chemotherapy. Dr. Alurkar?
Now we'll add immunotherapy, yes.
Okay, now you'll add immunotherapy. Now he's got convinced about it. So Keynote 061, and this is a trial, Dr. Babita, again comparing Pembro versus Pacli. Is again not combined with the chemotherapy. Is failed first line. And if you look at it, this is the CPS more than 1. Dr. Alurkar, it is not an easy choice to make. If you look at it more than 1, if you select patients, then it is actually not a very big difference, actually did not show benefit. But in a post-hoc analysis, when it compared more than 10 CPS, actually the benefit starts growing. So something in Pembro, in gastric, is looking at beyond 10 is where the benefit really starts off with single agent immunotherapy. And there is a Keynote 059, which is the single agent. It just tells you that PD-L1 positive is better than PD-L1 negative. That's something which you wanted to. Attraction again with Nivo, it shows that Nivo giving in a second line is better, but it's beyond 2 lines. This is what I'm speaking of. If you look at it, Pembro beyond 10 looks that okay, it is working better. It's again the MSI. All of us know, I'm not going to tell, but this is going to be one of the options which all of us are going to allude to, maybe in second line, maybe in third line. In MSI high, we would like to go for a immunotherapy at some point. And here again, single agent Pembro has shown to be beneficial than the chemotherapy. So where would you put the BEV, Dr. Rakesh? Ramesurumab. Last slide before we end actually.
Ramesurumab, I can go with the second line with the combination of the paclitaxel.
Okay, if you have not used it in the first line, you will go for the second line. Yeah.
Yes, sir.
Okay, Dr. Alurkar, Ramesurumab, your experience?
I have not used for gastric.
Dr. Babita, your experience? No?
Not used it, but I would recommend it second line.
You would recommend for second line and with the taxane, that's what you use. And if you use taxane, then if single agent also can be given. Okay, so this is where it is. For a palliative chemotherapy, HER2 positive, you have to look at it. You have to look at the MSI. You have to look at the PDL. You also have to look at the NTRK, which although I know the drugs are not available, that's now NGS is the preferred modality, is what the NCC now tells for. You can get everything in one go. That's what they meant, but you can still go for a traditional IHC based HER2 and other things as it is done. After you do the HER2 positive, definitely your targeted therapy becomes the standard of care. If it is negative or has failed at trastuzumab based, then as per the PDL, you can choose. Now you have option up front of Nivo plus chemo, which is still yet to be approved, but you can have the option. But for second line, you have options of either going for chemotherapy alone or chemo plus the Ramesurumab, or in a select group, you can go for immunotherapy. And that's also what we are looking at. So, to conclude, neoadjuvant approach in gastric cancer is a standard approach in operable cancer stomach. Chemoradiotherapy probably in inadequate nodal clearance. There was an intergroup trial which was positive, but to tell you to be fair, nearly 50% had a D0, no nodes were resected at all for that trial. So probably that's why that trial was positive way back when we were students. Advanced cancer, chemotherapy is an option still. Immune checkpoint is going to come in. Immune checkpoint plus chemo also is now positive, but trastuzumab is option plus chemotherapy in a HER2 positive, which is around 16% of the patient load. Immune checkpoint, first line pending approval, that's what we spoke. In a second line, you have options for beyond second line also. You have options for Pembro, you have options for actually Nivo. The benefit in Pembro at least is most striking in beyond 10%. In Nivo, it is much more broader actually. Otherwise, you have Ramesurumab, which is still there. In third line, it is still chemotherapy is approved as per NCCN. Best supportive care is option. Many patients are not fit enough, or a single agent immune checkpoint for the right patient is still an option. So with that, I really thank you for a patient panel. Thank you, chairperson. Thank you, panelists, for the inputs. Thank you, organizers. Thank you, Sandeep, for giving me the opportunity. So well on time.